awesome and amazing Wednesday, our Wellness Wednesday here on Tea or Coffee on High Impact TV. My name is Mudupe Jacobs and I have with me two beautiful ladies.
We're Ola Popola. Good morning.
Oluwaseun Olusegun.
Good morning, ladies.
Good morning, darling.
How's your night?
Fine, thank you. How was yours?
Awesome, thank you.
Okay.
So, today we have two guests on the show.
Yeah.
And we'll be talking about two different topics. First, we'll be talking about oral hygiene and care. And later on, we'll be talking about diabetic retinopathy.
Yes, definitely.
Yes. But talking about oral hygiene and care, you know, oral hygiene has to do with, caring of your teeth. That's dental care. But let me throw this question. How many times do you brush your teeth in a day?
Let me speak for myself because I don't know about some others.
It's fine. No, lip sealed. It's fine.
I brush mine twice. Sometimes, of course, I default. Usually in
Okay.
the morning before I go to bed. Usually the last thing. But then sometimes in Nigeria now you get home and
You're tired.
you still have the craving to eat something, and so sometimes I default. I still eat something after brushing my teeth. But then on the average, I brush twice.
Okay. How many times do you brush in a day?
I am not saying this because I want to follow her trend, but
Okay.
I actually brushed twice too. And with all
I do not have
sincerity, I
trust issues.
do.
I do not have trust issues, so I believe
Okay.
But another thing is when I have to take canned fish or fish,
Okay.
I try to brush my teeth because
Immediately after.
for me, I don't think taking sweet is enough. For
Like to brush your teeth.
yes, because everyone around would know that, oh, this lady just ate fish or
True.
something.
And
so
you could have something stuck in
yeah,
something,
so I
yeah.
brush my teeth after
Okay.
that. Yes.
So I thought you were going to ask me to, or am I supposed to escape that question?
Yes, please answer yours.
You
How many
started it, so
times?
you better
Okay, the
just
thing
talk.
is, I'm actually not diligent in that aspect. Sometimes I brush twice when I feel like, but
Okay.
most times I just brush once.
Okay, so let's assume
So
you brush
today's
twice.
topic is meant for you.
Okay, no, but oral, hygiene and care is very important. It's very
Yeah.
important because, there are so many things that can come up if you actually do not take care of your teeth. There are so many diseases diseases
No, it happens.
diseases that can come up,
Yeah,
if you
true.
don't pay attention to caring for your teeth. And, I think this particular topic is very important. It's important that we talk about it so that people will know just how important it is to take care of their teeth,
Especially
because
those
I know
ones with
most
mouth
people.
odor. Please let's talk about
Okay.
it. I'm sorry. I don't mean to be shaking tables, but then we're
No,
gonna
you
talk about
are
mouth
right
odor.
now. You are right now. From the way she's
sorry.
talking, it feels like you have
She
experienced one.
that
No,
someone
see,
in particular.
Mouth odor is traumatizing.
Okay.
I mean, sometimes now, let's not do the ladies just, but then sometimes you see someone all calmly, nicely dressed, very good looking, sometimes a good enunciation of English. And then they come near you and they'll be like, hi. Lord. And then you have some unnecessary things jumping out of you.
Exactly.
You have goosebumps, not out of excitement, but
I've
out of
actually had
freaking
that
out.
experience before. I was standing beside a very well-dressed, good-looking
See you,
man.
sister.
And, it just went, hi. And I'm like, I held my breath, like I was like, oh,
No, I always
Really?
tell people that aside you looking good physically, that's your dressing, makeup, and all of that, there are other dressings that you need to pay attention to. Just like what you said, taking care of
True.
your mouth, and not just even mouth, your body. You need to all of this is like a package for you to stand and look good because. Just like what you said, I can't imagine someone standing in front of me. When you see someone from afar, from the dressing, you're like, oh, you're
that
admiring
imagine,
such
you
person.
know?
And then, person walks towards you and, hello. No.
So before we talk a lot about the first topic, let's talk about our second topic, that is diabetic retinopathy. And that has to do with
Diabetes.
diseases, yes, that are caused by eye disease that is caused by
Diabetes.
Yeah,
yes,
complication.
yes. So, do you know anything? Have you ever heard of it before?
Yes, of course, because first, a lot of people do not know that diabetes can actually affect the eye
True,
or lead
true.
to vision loss.
Yeah.
Most people, when you hear diabetes, you just feel, okay, your sugar level, you need to cut down on your sugar level. Yes, that is important also. But then you need to take note that
Okay.
even aside vision loss, diabetes could lead to heart failure.
Really?
It could lead to kidney failure.
Okay.
So
Yeah,
there are so
over
many
time.
things. Yes.
There
So
are
and
complications.
this starts from you paying attention, proper attention to your health. Because when people just have diabetes, like, oh, okay, we'll use drugs, something
no.
to calm me down,
And then you
measure
cut
it.
out some food
But
and
One
then
funny
you
thing
need
that I heard about diabetes is, when you have diabetes and you urinate, and then you leave it and see if
And
ants,
ants.
yes, ants will climb
Would,
beneath
Fallacies.
fallacy. Yeah, I really don't know if that's true. I don't know if
Don't
that
worry.
works for
That
anyone.
could hold sometimes. It depends on where the urine. But then once you start seeing ants around your urine,
Okay.
God, that means you have this insanely amount of sugar in your
Sugar.
bloodstream.
Okay,
Then it does not
okay.
withhold.
All right, we've talked about diabetic retinopathy. We've talked about oral hygiene and care.
Yes.
And we have two guests in the house that will do proper justice to the topic. But then we have to go on break now. It's still Tea or Coffee on High Impact Television. Make sure you stay tuned because we are about to inform and educate you about oral hygiene and care and also to avoid diabetic retinopathy. And you do not want to miss out on this. So stay tuned. We will be right back.
Experience the excitement at High Impact Planet Amusement Park and Resort. Our state-of-art facility offer amazing outdoor rides, playhouses, indoor games, and dining facilities. Thrill your student with a lifetime memorable excursion trip. High Impact Planet. Fun just got real.
Discover the magic, the thrill. Every sight is so close you can feel it. The excitement, the fear. Experience our cinemas at High Impact Planet, the place where fun just got real.
Welcome back. In case you're just joining us, this is your favorite breakfast show on High Impact Television, Tea or Coffee. So before we went on the break, we were talking about our topic for today, oral hygiene and care. And so who is in the best position to do justice to this topic but a dentist? So in the studio today, we have a dentist. He's the lead dentist of Concierge Dentists, and his name is Dr. Deji Kobari. Good morning.
Good morning.
Good morning.
You're welcome.
Thank you for coming on the show today.
Thank you.
Yeah, thank you very much for having me here.
Yes.
Thank you so much.
So, as the topic says, what is oral hygiene?
Okay, oral hygiene. To start with, I want to say that dentistry or the oral health itself is not just about 32 teeth and the whole mouth.
Okay.
It's a study and treatment of human beings that have teeth. Because a lot of times people always assume that all we dentists focus on is on the teeth.
Teeth,
It's
okay.
just more than that. So the oral health is talking about the status of every structure that is inside the mouth. And much more than the teeth, we have the gums, we have the tongue, we have some other structures like the tonsils and also the palate inside the mouth. So oral health talks about, or oral hygiene itself talks about how you take care, how you make sure that the status of these structures are optimal, both anatomically and physiologically. That's just like a basic talk about what oral health and the care is.
Okay. So oral health and oral hygiene, are they the same thing?
Well, basically, they are, I could say they are the same thing. Oral hygiene is like a part of the oral health.
Okay.
Yes.
part of the oral health.
Yes, oral health is like the umbrella word for everything that concerns dentistry or the mouth.
Dentistry.
But oral hygiene is those things you now do to make sure that the structures in the mouth are in the optimal conditions that they're supposed to be in. Yes.
Okay. All right. So let's talk about dental cavities.
Oh,
Now, what are the common errors or mistakes people make in taking care of the teeth?
Oh yeah, there are lots of myths as regards dental caries. That's like the terminology we use for it, but we can also call it cavities. So to start with, what are dental cavities? They are holes. Let me just use the layman terminology. They are holes on the mouth or in the teeth rather, caused by the action of bacteria.
Okay.
Now, these bacteria, when we eat or when we take things that
Sweet
contain
things.
sugar, sweet things, and some
Yeah,
other things like that,
especially.
we call them substrates. Now, these substrates, which are remnants of this food on our teeth, when they remain on our teeth, bacteria act on them, naturally occurring bacteria inside the mouth. They act on them, and when they act on them, they produce acids. It is these acids that break down the structure of the tooth that leads to formation of holes. So that's dental caries. So there's some myth as regards dental caries. The one that's most common, which I found, in a lot of my patients, I talk to them and I talk to them, is they say it runs in our family.
It runs in the blood.
It runs in the blood.
What?
My dad used to have holes on his teeth, my mom, and a lot of things, but it's further away from the truth. It's not
Okay.
it's not the truth.
Genetic.
Yeah, because it's not genetic. Yeah, that's the right terminology to use. And although just like humans are, just like there's variation in genetics, some teeth could be stronger than some other due to some genetic things. But it all depends on what you do, even after you're born with those set of teeth, that will determine how you can be predisposed to forming caries or cavities. So like I said earlier on, it depends on how you consume your food, what you do afterwards. So now taking it back to oral hygiene measure, it's advisable for you to brush twice daily, in the morning and last thing before you sleep at night. So most of the time when we eat our shawarma,
Did you hear that?
you do a lot of things. Maybe you go to the mall and you eat, you indulge in stuff, and at night you do not brush your teeth before you sleep. It's just logical. The remnants of those food are left on your teeth, and bacteria
Yeah, we
are
act
so
on them.
active at that time because you are at rest. It's been found out scientifically that when we are at rest, we are not producing saliva, bacteria act faster. So what they do is they act on these remnants, they produce acids. These acids break down the structure of the enamel. The enamel is the strongest structure in the human body, even stronger than bone. But as strong as it is, it dissolves in the presence of acids.
Wow.
So this is what leads to holes. So you can find a sibling, like we had a dental checkup in my church last week after service on Sunday, and I checked a family, the girl didn't have holes, but the boy had holes on his teeth. And the dad was like, I thought it was the girl that should even have holes.
Why?
Why? Why would it
He
think
just
so?
thought so. He told me
Assume.
because, so it's like an assumption. So it doesn't run in the family. So that's one myth that I always like to help people
Correct.
debunk and correct. Yes.
All right, but sometimes I was telling them that I do not like brush my teeth in the night.
Okay.
Sometimes I'm guilty. But what I do is I take gum, and not just any type of gum. It's particular gum that dentists actually approve that you can take.
Yeah, sugarless gums.
Exactly.
Okay.
So is that also advisable in place? Can you use it in place of actually brushing it?
No, you can't. No, you
You
can't.
see, you try to
It's a
explain, but then
no-brainer. I'm not even the dentist to know that.
The gum wouldn't brush your teeth for you.
True.
Yes, the gum wouldn't remove remnants of the food you've eaten off your teeth for you. You understand? So that's one reason why it won't replace. Another myth that we always help people to debunk is they say when you remove one tooth or when you have hole on one tooth, it jumps to another.
To the other.
It doesn't. The
Okay.
teeth are independent entities in the mouth.
Okay.
Now, what happens is this. I always let my patients know a lot of times when they come to the dental clinic. You see a patient who comes to the clinic and has a hole on a tooth. And this tooth, after proper examination and taking x-rays, you realize that a lot of the crown of the tooth is gone, so we have to extract this tooth. So you tell the patient tells you, some while ago I went to see the dentist, I extracted one tooth. Now I'm going to extract this tooth. So they're like, doctor, dentist, does it mean that this thing keeps jumping? Am I going to keep extracting?
The other.
So what I tell the patient is this: the last time we went to see the dentist when they extracted the previous one, did they tell you to come back? most patients will be like, yes, I was told to come back. And I'm like, did you go? They say, no, I didn't go. So I'll tell them that what happened when the dentist asked you to come back was that this tooth we are extracting right now most likely had a hole on it as at then. Now, the hole was still small, so the dentist thought you should come back for a filling. Because most of the time when someone is in pain, we want to attack the most important thing first. We want to treat the first and the most important thing. So the dentist is like, you can come back next week for a filling. Now, if you don't go back for that filling, that hole that has been formed keeps going deeper. And maybe a few months later or a year later, it gets down and you're coming back again. You're like, it jumped. It didn't jump. And at that point, when I was treating the patient, sometime I would tell him, you have holes on about 2 or 3 other teeth. And they're like, so I'm like, if you don't do this now, next time you come again, you think it has jumped. No, it hasn't. So that's another thing that I love to do.
Okay, talking about holes in teeth, tooth. I'm trying to get a graphic and a mental image of it. How do they get formed? Okay, you mentioned something about bacteria causing acid in the teeth. Is it that the more of the acid that is produced, then the more it drills and makes into a hole? How do we have holes formed in the teeth?
Okay, I'll take you to basic oral biology.
Thank
you.
you.
You know, we should have something like a board here and a marker, like we just draw some things rather. Okay, but I think I'm going to explain as much as I can because what we can see on the teeth right now is what we call the crown.
Okay.
The
white part is the crown.
Yeah, the white part is the crown. I made a post yesterday. Yeah, it's the crown, but the part that is covering the crown here is the enamel.
Okay.
Yeah, I'm still going to explain now. I made a post yesterday on social media and talked about the fact that there's still normal concept.
I need to jot down a lot of things.
There's this normal concept of the iceberg. So there was one picture I saw of something that looks like a tooth, but the crown was above sea level, so the root was inside. So I was trying to tell people that, you see, just like the way we see the tip of the iceberg, most of us don't know that 2/3 of the length of a tooth is buried in gum, in bone. So we have the crown, which is like 1/3 of the length of a tooth. Then we have the 2/3, which is like the root inside.
So this one now is crown.
It's crown.
Okay.
And the part that is in the crown that we can see right now is the enamel. Now, apart from that height difference, there's also some levels into the tooth. There is the enamel, which is what we can see now, which is the hardest structure in the body. It's very hard, and you don't feel any pain when anything touches it. Then inside, after the enamel, the next level is the dentin. The dentin carries some sort of sensitivity. And inside the dentin is the pulp. The pulp is the one that carries the life of the tooth. That's where we have the nerve and the blood vessel. If I should pinch you right now from basic integrated science, they say irritability. So the reason why you can feel a pinch or a pain is because there is a nerve connecting that part of your body to your brain. So the nerve that connects the tooth to the brain is inside the pulp. The blood vessels that supplies life to the tooth is also inside the pulp. So that's why when holes form on the enamel, you may not feel any pain. So you see a dentist through a normal dental checkup tell you have a hole on your enamel, you need to feel it as soon as possible. And you're like, well, you don't feel any pain, like in normal Nigeria, you're also around and you're like, it has not pained me yet. It gets to a point where you start taking sweet things or you drink cold or hot drink, you feel some sensitivity. At that point, the hole is at the level of the dentin. Then it gets to a point where the hole goes deep, the more the acids are being produced. And once the first barrier, the enamel, which is the stronger one, has been broken, it's easier to just go deep down. So at that point, when it gets to the pulp, the pain can start anytime. Because that's where the real nerve is. So that's like explaining the progression of dental caries, in layman's
Are you sure you will not
terminology.
brush after taking that? I'm just saying. Okay, so now let's talk about, because changing color of the teeth, changing. I've seen situations whereby I see people with yellow teeth, brown. What causes that?
Okay, discoloration, it's a big issue in dentistry and even in that field entirely. And there are a lot of things that can cause discoloration, but most of the time we will group it into two. We have the extrinsic and the intrinsic.
Okay, what do you mean by that?
Extrinsic, external. Intrinsic, internal.
Okay.
And some could be caused, by malformations from birth. A very classical example, they tell pregnant women not to take tetracycline. because the things the mother is taking while carrying the pregnancy of the child can affect
The babies.
the fetus, because there's always, through the umbilical cord, the placenta, there's always a connection between the mother and the child. So that's why some people, when they are born, they have tetracycline stains on their teeth. When the child is growing up, if the child should get indulged in maybe herbal concoctions, it could cause stains on the teeth.
And it can't be corrected?
It can, definitely.
Okay.
It can be
Whining, I
corrected.
suppose.
You know, so then the extrinsic ones could be due to, well, tea, coffee.
I'm not taking that. No. I have been taking this for a while. No. See my teeth.
You know the interesting thing about dentistry and our field entirely, which I love so much, is that except for some emergency cases, lots of the things we treat take a long time to manifest. When I see a hole on a tooth, that hole would have started at least 1 to 2 years earlier.
Wow.
Really?
But do you have the symptoms that would make you know that something is wrong, except it gets to that point where you need
Most of the time, you may not know yourself, and that's why we always recommend you see your dentist at least once in 6 months.
Okay.
Yeah, like during the last checkup I did for some people, you know, and I told the lady, you have a hole, it's very, you know, small, but it's deep inside. She was like, I don't know. I'm like, yeah, because the surface of especially the back teeth, they are rough. They have grooves and fissures.
Okay.
So even if you run your tongue around there, you won't feel
You
anything.
don't feel anything.
All right.
So,
For discoloration, you
Okay,
mentioned
yes.
tea or coffee, except black coffee, right? Or what do you think?
No idea.
But this particular one, no. I don't agree with
Well, I
you
don't know
on
the
that.
kind of coffee, but you know, a lot of times I've seen patients that come in for scaling and polishing. That's the
Okay.
routine cleaning, and you see stains on their teeth. You know, and you're like, oh, do you take coffee a lot? You know, some of them are like, I've been taking coffee for all these years. I'm not saying taking
Okay,
coffee
long
once in a
term.
while.
Okay.
Yeah, that's why I said
For
most
long-term use,
of, most
okay.
of the things we treat, some of them, you know, they occur over a long period of time. Some of them. So like discoloration, even naturally, aging can add to discoloration.
To discoloration.
Yeah, as we
okay.
grow older, you know, can get the color of
Okay,
the teeth.
so there's actually one thing I've been meaning to ask. You know, there is this. I'm not shooting myself. I'm not shooting myself.
Everybody asks questions from their
You know,
experience.
sometimes the teeth grows in an abnormal way. Like it's not the normal straight. Some
Okay.
people's teeth, like I'm not putting my teeth now, but
Yeah.
you know. But so what causes it? Why is it that some grows like inside out?
Okay.
What causes it?
Thanks for that question. You're going to be making me talk about a whole field in dentistry.
Okay.
I'm going to be very brief about it. That's what we call orthodontics. You know, in
Okay.
medicine generally, orthopedic. Ortho is straight, from
okay.
the Greek word straight. Pedic is a leg. In dentistry also, ortho is straight, dontics is teeth. So it's a specialty that deals with straightening or arranging teeth. So what causes it? It could be from birth. It could be hereditary. Yeah, just like you give birth to a child, it looks exactly like the father.
father,
You could inherit your teeth from your parents.
Oh, okay.
Yes. So you
Okay.
could,
Now I know who to check for my teeth.
yeah.
Okay, you
can.
talked about hereditary now
Yes.
for the set of teeth, but you cannot inherit hole in the teeth, right?
No, you can't.
Okay.
You can't.
I just wanted
You
to
can't.
get that
Yeah,
clear.
because most of the things that causes are external factors.
Oh, okay.
Substrate, the kind of things you eat, time, and also the surface of the tooth
Yes.
and bacteria. So
Yeah,
those are
hygiene
things you can.
practices
Yeah, oral
too.
hygiene practices exactly.
Yeah.
So
Okay.
talking about oral hygiene practices, because I know our time is fast spent. Brush twice daily, as much as possible. Floss at least once daily. Why do we use floss? You know that thin thread. Yeah, we use it to clean in between the teeth, the tight junctions that your brushes can't get into.
Okay.
Yes, then see your dentist at least twice every year.
I have a question.
Okay.
I was going to ask it immediately after we were talking about, she was talking about colors of teeth and all that. Some people say that yellow teeth are sort of stronger than the white teeth. It brings me to a question about teeth whitening. Some people say when you whiten your teeth, it weakens your enamel. Is that true?
It can if it's not properly done.
Oh, okay.
Now, I always like to let people know that the natural color of the teeth is not pure white. It's a range from like silver down to golden yellow. Because what you're seeing basically is the color of the dentine that is inside the tooth. So it's not pure white. Just like the color of the skin, some people that are dark want to become yellow or fairer. So some people may want to whiten their teeth. So teeth whitening, a lot of time when people come to tell me, I want my teeth to be whiter, the first thing I tell them is, look at my teeth. Are they pure white? They're like, no. And I'm like, I'm okay with teeth. It's okay with my skin color. So teeth whitening or bleaching is not for everyone. But for someone who has tetracycline stains, so for someone who has stains due to herbal concussion used when she was small, it can whiten the teeth.
Okay.
You
So
understand?
our time is fast spent.
Oh.
So just give your last words, advice to people out there, you know,
Okay.
how to take care of their teeth.
Oh, okay. The first thing, especially as regards dentistry in Nigeria right now, is we need to do a lot of awareness, which is why, you know, I was so passionate about coming up when I had opportunity to do so. So people should, take care of their teeth. Simple. Brush twice daily, using a medium textured toothbrush.
Medium
Not hard.
texture.
Yeah, not hard and not
Instead
so
of using
soft.
brushing tires.
They're using any toothpaste that contains fluoride.
Okay.
Any toothpaste that contains fluoride.
So now
Yes.
when I'm going to purchase
Then-
toothpaste, I'm going to check the ingredients.
Yeah, then in addition, this is what I know a lot of Nigerians have not yet inculcated the habit, is to visit your dentist at
Dentist.
least once in a month,
Okay.
in 6
In
months.
6 months.
All right.
Thank you very much for coming.
We're
Yeah.
so glad, you know, to have
Yes.
understood more and then cleared some fallacies too. And
Yeah.
so, you know, from the bottom of our hearts, we just have this little token
It's
for
not
you.
little,
So-
my dear.
So thank you very much.
Thank you very much.
And we
Thank you
hope
so
that, you know, if we call you one of these days again, so please come and do more justice. You will heed our call.
Yeah, definitely.
Thank you.
Thank
very
you for
much.
coming.
Yeah, thank you so much.
Okay, so the show still goes on, yes?
Yeah, definitely.
And, you know, we have our second guest after this break that we're talking about
diabetic retinopathy.
Yes. Okay, so please stay glued because we will be right back after this break.
Walking into comfort in a safe environment is every family's dream. At High Impact Planet Resort, our fully furnished service apartment is a home away from home. Amazing views right in your luxurious world. Work out to keep fit for an amazing body at the gym. Get affordable groceries and personal care items at the supermarket. Feel relaxed and beautify yourself at the fully equipped spa. High Impact Planet. Fun just got real.
Welcome back. It's still tea or coffee on High Impact Television. You know, before we went on break, we talked about oral hygiene and care. And we had our guest in the studio to talk about it.
Yes.
And right now, we have another guest. He is Dr. Tunji Adenekon. And he would be doing justice to diabetic retinopathy. Good morning.
Good morning.
Good morning,
So you're welcome.
Nice to be
Good
here.
morning. Okay, now, diabetic retinopathy. When I was researching about the topic, I realized that the estimation of 422 million people actually have diabetes. So now, and diabetic retinopathy is a complication of diabetes. So In your own language and word, how would you describe diabetic retinopathy?
All right, thank you. Diabetic retinopathy is the leading cause of blindness in diabetic patients. It's also to let you know that it is the earliest sign of complication of diabetes. Complication of diabetes is beyond the eye. We have the heart, you have the kidneys, you have the skin, you have even the nerves that are affected. But diabetic retinopathy is the earliest sign to tell you that this person is beginning to have problem with the blood vessels. And that is why we say that the eye is a window to the soul. Look into the hand of a diabetic, you will know that something else is going on. And before the patient gets to kidney failure and all, you might be the first to pick of that patient. But diabetic retinopathy is beyond just the word retinopathy. There are three things that we talk about in diabetic retinopathy that cause vision loss in diabetic patients. These include vitreous hemorrhage when they bleed into the eyes. These include the actual retinopathy that causes fibrosis and detach their retina. And the other part is the macular edema. The macula is that area where we have a sharp deflected vision. It's also responsible for colors, for you to see colors. So when they have swelling in that area, which we call macular edema, there's going to be profound visual loss. And these are all related to the glucose level in the body.
Okay, you mentioned colors. Now, what are the symptoms aside color, changing of color of the eyes? What are
the
other
usual thing is
symptoms?
that it doesn't give symptoms.
Wow.
If you don't check, you don't know it's there. The first time it gives you symptoms, there's already a big problem. And usually it's one of these three that I've mentioned that will have happened. That means that person has sight-threatening diabetic retinopathy. But it's most interesting to know that 1 in every 3 diabetic patients already have some varying degrees of diabetic retinopathy. 1 in about 10 is already having a varying degree of sight-threatening diabetic retinopathy, which I mentioned those 3 main factors for you. But what is important is that you need to check so that before you get getting to where there's sight-threatening, we can begin to prevent, because they're usually avoidable if you do your proper screening and check.
Okay.
So what we are trying to do now is to make sure that we work with the endocrinologists. Those are people managing diabetic patients. With family physicians, those are people managing diabetic patients. The nephrologists, those are people managing renal disease from diabetic retinopathy. We work with the cardiologists, those are people managing the heart problem. So every other person, you are looking at an integrated care where what we call it a one-stop approach. You get to one center, in one whole clinic, you will see every specialty that has to do with diabetes. That is where we think we should be. But the real problem there is that we are still trying to create more awareness for people to know, because about 66% of diabetic patients are yet undiagnosed. They have it, but they are undiagnosed right now. And if you look at it, the problem we have in Nigeria, or let me say in Africa, is that I think in 2014, the International Diabetes Federation, they brought out the statistics that about 40 million people are affected with diabetes in Africa. About 1/3 of that are in Nigeria alone. And it is expected by year 2040, we are going to double, in fact, 109% increase. We are going to about 34.
As at now, World Health Organization, they've mentioned that it's 32 million as at now. Because I checked this morning and 32 million from 14 million, you can imagine.
So it is alarming. And it is worse for us because about 1/3 of this will be in Nigeria. And you can imagine, right now, the current estimate that 6 million people have diabetes mellitus in Nigeria. About 2 million of that already have some varying degree of diabetic retinopathy. And it's 1/3 of this that we talk about, the sight-threatening issue that we have not even seen to be treated. And if we don't treat it on time, they might have, what do I call it now? Uncorrected, or let me say, blindness, irreversible visual loss.
Okay, you know they always say prevention is better than cure. Now, you said there's no symptoms for you to know. How do you know?
Now, there are symptoms. What I've said is that before the symptoms comes in, then you need to check. If you wait for the symptoms to come, you already have some varying degrees of sight-threatening diabetic. Like I gave you an example, blurry vision, visual loss, inability to focus on detailed objects. You begin to have things like objects in the house becomes bigger than normal. Your spoon that you used to eat, they look bigger than normal. In some people, their plates look smaller than normal. Oh my God. These are what I can use the medical term for you is macropsia and micropsia. Micro is small, macro is big. You have things like what we call metamorphopsia, when you have distortion in image objects. When all these are going on, we should look at the macula. There may be a problem. If it's retinal detachment that has come up, you find out that some people begin to say, I have like a cutting drop in my vision. I see someone is closing a curtain or raising a curtain, dropping my vision. Somebody said I can't see to a particular side of my vision. That means something is going on there. Those are people that have that. The other part is the vitreous hemorrhage. You just like we are all now, God forbid somebody else has diabetic retinopathy now. We'll leave the studio now. As we walk out, somebody just say, I can't see. I'll be wondering, is this African remote or what has happened to me? But it's just because the person suddenly bled into the eye, which is vitreous hemorrhage. So those are the major things. But there are other things that happen for you to know that, okay, this person may be a side of diabetes. Like we talk about boil on the eyelid. If somebody is having recurrent boil on the eyelid, it may be a time for you to check if your fasting blood sugar is above normal. And oftentimes we have diagnosed people with that alone.
Okay, so what are the types of diabetic retinopathy?
Oh, there are different grades.
Okay.
But the current one we are using now is to talk about the non-proliferative diabetic retinopathy, the proliferative diabetic retinopathy, and what we call the advanced eye disease. In non-proliferative diabetic retinopathy, it's just so that there are leakages from the blood vessels as a result of damage from that excess and prolonged high glucose in the body. It affects the vessel wall so much that content within the blood vessel, they leak out. And these include fats, it include blood constituent, and we call it hemorrhages. So depending on how you see and how much of them you see may give you an idea that this is the level of the diabetic retinopathy. And they are graded from mild to severe. Now we move to severe because we want to treat early. There used to be a term called very severe. But that doesn't matter anymore. Now once you get to severe, you are getting close to having new vessels. So what happens really that there can be occlusion, there will be closure of the blood vessel. And when there's closure of the blood vessel, what happens? The body does not get the nutrient. It doesn't get the blood supply. So it tells the brain, come on, I need blood here. Please, flourish. And the body will now start producing what we call the vascular endothelial growth factor, which we all need. We all need it to produce vessels. We all need it for our vessel growth. But at this stage, we are adults. We don't need enough of it. So the body will now start producing too much of it. So they begin to produce new vessels. And those new vessels, their wall is not correct. It's not complete. They lack a lot of structures. And they are friable. At the last, if you move your eye rigorously, you can rupture any one of them. Wow. So if you think it's time to be looking around and you're a diabetic patient, you may have to. And sometimes what happens is that because of that, they are lean. The too much pressure going in, that's why I talk about hypertension now. Too much pressure going in can burst them. And because they are not as strong as the regular ones. And when they bleed into the vitreous. And in the process of taking it back, they also contract. In contracting, they take the retina along with them. And they pull it and detach it. And that's what we call tractional retinal detachment.
Okay. I'm trying to lot of
I know,
pathogenesis and degeneration and everything. Okay, so judging by the progression, are there conditions that can worsen this thing? Is it possible for maybe someone who has started from the first stage to just jump from that first stage to the next stage or to the end stage simply because of some conditions? Are there conditions that can worsen it?
Yes. You start with what are the risk factors for even developing diabetic retinopathy? Yes, you are diabetic. Number one thing, we have what we call modifiable risk factors. And we have the non-modifiable one. Excuse me. The modifiable ones are things that you can adjust on your own. And that has to do with hypertension. I think you can decide not to be hypertensive. It has to do with smoking. You can decide that I don't want to smoke. Those are other things that you can look. You can decide that, okay, I should make sure that I do my regular exercises so that I don't have too much fat in my body and all. So as well as the glucose control. You can decide. There are diabetic patients that don't care anymore, whether there is control or not. They don't care. So these are things you can work on your own. But the non-modifiable one, I think that you can change, like the duration of diabetes. That means you had diabetes by 10 years old. Of course, you will grow. So by the time you are 20, it's called 10 years duration. You can't adjust that. You can't say, I don't want to grow. Those are other parts. Or pregnancy. You can decide not to be pregnant, but once you are pregnant, there are things you may not be able to adjust because your pre-pregnancy state is very important. That's also what the obstetricians are brought into this integrated care that we're talking about. We need to know your pre-pregnancy state. And also, when you are pregnant, maybe you didn't control your pre-pregnancy state, you are pregnant, we also don't do rapid reduction of your blood glucose if it's too high, because that one too can cause a problem. That's another non-modifiable factor that you work on. Renal disease. Somebody with renal problem, kidney problem, that's what I mean by renal disease, is also another risk factor for developing diabetic retinopathy. So among all these, the greatest factors will be glycemic control, duration, because it is known that if somebody becomes diabetic, in the next, by the time the person gets to 15, 17 years, 50% of them develop diabetic retinopathy. If by the time he's,
Even if you control
that's
it.
type 1. I'm talking about those that have type 1 diabetes, those that have to use insulin because of lack of, all those ones, they start from childhood most times. So those ones, you will have known that this person is diabetic. It is type 2 that don't know that they are diabetic, usually adults. You might know by just checking their, I can't see you, and just come to the hospital, I see some things, I see the hemorrhage, and I say, please go and check your sugar, and the person comes back being diabetic. That may be the first way to know. So it is known that for type 1, by the time he's 30 years, 90% of them develop diabetic retinopathy. But why for the type 2, it's 5%, meaning that people don't know until they come to the hospital from one vision problem or the other. Sometimes somebody comes to you, I want to screen myself for glaucoma. I think I can't see something that is near. I think I need glasses. By the time you look inside, you see that there are features of diabetic retinopathy. Are you diabetic? Are you a diabetic patient? And I say, yes, I am. That's how you know that there's a problem.
Okay, so as a vitreoretinal surgeon, now at what point would the surgery be required for the eye?
Okay, at these main 3 areas, by the time you have what we call severe non-proliferative diabetic retinopathy, that means that your vessels are not started to bring new vessels. They are not bringing, your eye is not bringing new vessels yet. But we are already seeing that there's already lot of no areas with no blood supply in your eye. That's one by severe non-proliferative. We treat you with laser photocoagulation. What do we do with that? We burn your retina so that they don't demand for oxygen and they don't demand for too much blood supply. That means that we don't want you to produce new vessels to them. But in all this, you still have to control the blood glucose level. If you don't control the blood glucose level, you still have a risk. But then we will have reduced your rate of development of diabetic retinopathy or reduce the progression of whatever you have had. If that doesn't work, should you have swelling in the macula, that's what we call the main area of the eye. Should you have a swelling there, which is called macular edema, then we begin to talk about giving you laser too, or giving you an injection that works against the inflammation, which is the edema that you are having. And I can tell you, you get it monthly.
Wow.
And the first treatment is 3 monthly. The first treatment is over 3 months. So you get 1, 2, 3 in the first 3 months. Then we review it. When we think you need more, we can be giving you every month for the next. In a year, some people get about 8 injections. And one injection is not as cheap as you may think.
I was just about to ask that, what is the cost?
As you may think.
It doesn't sound cheap.
It is not. The minimum one, you go for like 30, 50,000 naira. But the ideal one that the studies have been done and it is licensed to give in the eye, the minimum is about 150,000.
Wow.
So if you cut, that means in 3 months, you are spending 450,000.
Wow.
But with just maybe 5,000 check, you will have prevented this. With just checking and making sure that you are even diabetic. Because what I care, what are the preventions? You first want to be sure you are not diabetic. Only a diabetic patient can develop diabetic retinopathy. So prevent diabetes. Prevent, and most of us don't. There was a day I just look at myself. I leave from my house to my car, from my car to the office. I enter the office, I sit down. Well, at ophthalmology, we sit down to look at most patients because of our instrument. I sit down in the theater, I sit down, I finish that day. Then the next thing is that I go, I move from there. The next thing is that I go home too, in my car. I'll be in traffic. I get home again, I go upstairs. Sit down, watch TV, watch football. No activity. Eventually, what will happen is that you will discover that this is all you do. The day I say you climb the stairs, you find out you can't even climb the stairs anymore. That is the sedentary lifestyle. But we think it's enjoyment. I was in UK for the first time in April, and I did a lot of work. If you have been there, you walk everywhere. Once you come there, and it's brisk walking. They all do. They're walking as if maybe it's the Harmattan that is causing that, I don't know. or the winter. Everybody's walking around. But here, we feel it's time to move on the road. So much sedentary that we don't do enough exercise, honestly speaking. And that is one major factor, because the diet we all kind of engage in now is Western.
But for me,
and we need
for
to
me,
burn
I
up
think
those.
driving in Lagos alone is an exercise on its own.
No, you don't do.
If
Like
you
I
would
want to ask my
me-
patient, my dad. I want to ask my patient, do you do exercise? He said yes. How do you do exercise? He said, I walk around my bed.
It's
So
hilarious.
you are driving, you think it's exercise. I can tell you that thinking also is exercise. You need to move from. You need to burn some energy, burn some calories. So if you are driving, yes, that's the sedentary. So if I even drive with some swag, you know, And you'll be like, yeah, that is not exercise.
Wow.
Okay.
Okay, one last question because we're running out of time.
I know.
Can it be corrected finally?
What we are talking about is screening. Screen people for diabetic retinopathy so that they don't develop the sight-threatening part of it. So when you pick it, you can nip it in the bud, treat it, and so people don't develop all those other ones. But by the time you start treating patients, eventually, it may not be that successful if it's late. But how do you prevent blindness? Like I said, don't become a diabetic patient. Okay, you become a diabetic patient. How do you prevent diabetic retinopathy? Control your blood glucose. See your endocrinologist regularly. See all those. Go for your checkup regularly. I can tell you it's very difficult, but you have to maintain it. But in diabetic retinopathy, how do you prevent that? You need to check. If you're a diabetic patient, check your eye at least once annually. There are guidelines for you to know, depending on the stage, how often do you need to see the ophthalmologist again. And it's just our eye-seeking behavior here is not good enough. And we are still far from where we should be compared to how it should be. Because right now, you see a patient now, you say, please visit again in 3 months. Even that 3 months, that patient will not come. But 6 months will not come. Patient will return in a year. And by the patient is coming in a year, it will be like another yes, it was. So what I tell because sometimes there's a guard and okay, there are too many people today, we can't see all of you. If you're a diabetic patient, there is no guard. You have access to your doctor. Because I cannot say because you didn't come 3 months, so you should come another. I must see you anytime you come. It's just that it overworks me. It's like a burden. But I make sure that every diabetic patient that comes is seen. Because that may be the only time I can see I will see that patient. I don't know what else that patient will go and do thereafter.
True. Okay, so apparently we still have time to ask a question or two. So you were talking about before that, during the commercial break, you said that diabetic retinopathy is not the only eye condition. That arises from diabetes. Yes. So what other?
Okay, let me start from, like I said, refractive error. If somebody has too much blood glucose, that's what we call hyperglycemia. The body, the eye will behave like it's short-sighted. But when person has too low, the eye will behave as if the person is long-sighted. Okay. So there will be frequent change. The glasses, except the only time when you are normal, that glasses you collected when you are normal will work. But people will keep changing glasses. They don't know that it's a sugar level. Then too, we have to talk about boiling the eye, which we call a sty. Okay. It's like you see somebody with boiling on the eyelid. That's one of them. We also talk about blepharitis, lid lash infection. The eyelash, you can have infection there. It is common in diabetic patients as well. You can look at the iris, which is the brown or black part in some people. You see that there are vessels growing on it. That tells you that at the back, there are a lot of new vessels. So they have grown so much that they are showing the front. Cataract is also one of them. Patients develop cataract. Glaucoma, because of those new vessels growing in the angle where the fluid in the eye should drain through. So they cause an obstruction, and there's built up of pressure in the eye, and that affects compression of the optic nerve at the end, at the back. So that can lead to glaucoma itself. So these are other things that also happen in them. There are other features we look, which may not be too worrisome, but there are features to tell you that this patient has diabetic retinopathy, except you check. So there are other signs, and as little as, like I said, frequent changing glasses. So you go to this, say my glasses not good. After 6 months again, you go to another clinic. There you go. It's a time to check your sugar.
Okay. All right. For me, everything on the head, I think there's a connection between the eyes, the nose, the mouth, and the ear. Because, at times when I use eye drop, probably when maybe it's itching or something, and I feel it in my mouth. So there's this kind of connection.
Can I quickly mention that to you?
Okay.
Okay. Towards the nasal, that's the nose area of your eye. There's what called the lacrimal drainage system. That's your tear drainage system. Okay. That's the one that collects. If you open it, you see a dot somewhere there for like all of you now. Like I tell people, you are looking astonishing now. You are looking good. But how many times do you take care of that eye? You put contact lens, you put eyelash, you color it as the way you want. But did you check it? So what happened in that case, when you put that eye drop, even your normal tears drain through that place. And it has a sac. Through that sac, it goes down. So when you blink, the muscles surrounding the eye contract. So it pumps what is in that sac
Down.
And that place open into your, what we call the inferior meatus, which is in the nose. It opens there. And that's why I tell people, so much so that when you cry excessively, you begin to have,
Yeah.
Yeah.
it is that your connection that is bringing it.
Okay.
Thank you very much for coming.
And thank you very much for your time.
Thank you.
And your patience in explaining all these terms to us. Now
telling
I
you.
understand more about, okay, I knew that diabetic retinopathy was a complication
Yes.
in diabetes. Now I know more about it and all those terms. Macular edema. That is not going away.
Thank you.
You know, all those
It's very
uterus hemorrhage.
Oh, good. I should give you an honorary doctor now.
Okay, I deserve it. So thank you very much. And then we talked about oral
hygiene
Let me
and care.
ask you now, I'm your teacher. What have you learned today?
Okay. I learned that I should brush my teeth twice a day.
Yes.
Which I must stick
In
to.
fact, for Modukwe, when he, the first guest was explaining, I was just looking at her. I hope you are jotting down.
Side-eye.
That kind of side.
But, you know, I learned that I should brush my teeth twice. And I should see my doctor once in every 6 months.
Yes.
Yes, and I should, you know, I shouldn't rely only on sugar-free gums because I know I do that a lot in place of,
And
in place
you
of
need
brushing
to
my teeth.
stop.
I can imagine how you think that.
I didn't say I
Laziness.
brush, but not
I'm
all the
judging
time
you.
in the night.
Okay.
You know, but you know, now I know that I should do it all the time. That's what
yes.
I'm trying to say.
Okay,
Yes. Why
and-
crucify me?
Okay, there's one major thing I learned, but in the first segment and now, during oral hygiene and care and diabetic retinopathy, he mentioned that you do not have to wait till when you start having complications or
yes,
symptoms
yes.
before you check yourself. And the first guest also, Dr. Kowobari, also mentioned that you need to go and do regular check for yourself because it now prevention is better than cure, like you know.
Definitely.
So you do not need to wait to spend. He mentioned that you can spend 5,000 just to check yourself. Why now wait till when you have to start spending 150,000 naira in a month just to cure something that could be prevented? So I've learned to always check myself.
Yes, and
sometimes-
prevent diabetes also.
Yeah. Sometimes when you start to see the symptoms, sometimes it's too late by the time you start to see the
Yes.
symptoms. So
Yep.
Okay, so
Thank you so much.
very much, sir. And yes, for coming on the show, we have this token of our love. Thank you.
thank you so much
Thank
for
you
coming
very
on the
much.
show today.
I'm grateful.
And we
Yes.
hope that, when we say, please, sir, come and tell us more about this particular
Of course.
topic, you will not turn us down.
I'll be glad to
You've
oblige.
given your word on live TV.
It's okay.
Thank you, sir.
I'm always
All
available.
right, so that is all that we can take on Tea or Coffee today. But be sure to join us same time, same station tomorrow for another exciting and educative episode of Tea or Coffee. My name remains Modupe Jacobs.
And I am Raola Pupola.
And I am Oluwaseun Olusegun.
Enjoy
Till
the
meet
rest of
again.
your day.
Bye.
Bye.
Bye.